Untreated drug and alcohol use contributes to tens of thousands of deaths every year. Substance abuse affects more than just the person who uses, but their friends and family as well. In 2019, over 70,000 drug overdose deaths occurred in the United States. During this episode of Banner Health's Making the Rounds, we're going to be addressing the stigma that surrounds addiction. If you are new to our podcast, thank you for tuning in. And if you are a regular listener, welcome back. I'm your host, Christopher. With me today is Dr. Elisa Gumm, Program Director of the Addiction Medicine Fellowship at the University of Arizona in Tucson, and Dr. Luke Peterson, Associate Program Director with the Addiction Medicine Program for the University of Arizona in Phoenix. Thank you both for joining me today.
Pleasure to be here. Thank you.
Yeah, it's a wonderful opportunity to talk about what we love.
Dr. Peterson, in our previous discussion, you shared with me that the opioid epidemic is at an all-time high. Why is that? And could you share with our listeners an overview of the epidemic?
Absolutely. In fact, you said at the beginning that in 2019 that there were 70,000 drug overdose deaths in the United States, and now we're seeing, at least as far as the data is from this last year, that it's probably now over 100,000 drug overdose deaths. So the numbers continue to climb, and we haven't really seen a curve in the increase in deaths yet. We've seen some communities and states have a decrease in overdose deaths, but that was prior to the COVID-19 pandemic. And those were communities that did a great job about getting naloxone into the hands of people who are using and the families of those who are using, who got medications for opioid use disorder to the masses, and really did a great job of harm reduction and getting treatment and destigmatizing substance use disorder. But in general, across the United States, we haven't seen that. And so we continue to see drug overdose escalate. The pandemic has had an interesting effect because some treatment centers during the beginning of the pandemic closed their doors, but there's been a lot of isolation. There's been a lot of job loss, which then, health insurance loss comes with that, and so ability to access treatment has been impaired, and just that, the isolation and the fear from the pandemic has led to a lot of depression and anxiety, which I think is also fueling the drug overdose deaths that we're seeing. I'll say another thing that's interesting is that the majority, or at least more than half, of overdose deaths are polysubstance, meaning it's not just an opioid. It's an opioid laced in somebody's methamphetamine or cocaine. It's the combination of a benzodiazepine or a sedative, sleep aid, with an opioid. And so we've also seen across the course of this COVID-19 pandemic an escalation of other substance use, including alcohol, that is also likely contributing to people taking multiple substances and overdosing more easily.
Dr. Gumm, any comments?
Yeah, I'd like to, echo those same sentiments down here in Tucson. We have, we were kind of with our program hopeful, in 2019, coming into 2020, in March of 2020, in the very beginning, we were hearing reports of a potential 4% decrease in overdose deaths. And then with the pandemic, that was quickly went away. And the overdose deaths have just escalated the total overdose deaths, and that has been kind of a fight or a race to get as many people into treatment. We too are seeing an increase in other substances, including alcohol, methamphetamines, etc. But we're also starting to see an explosion of synthetic substances, and these are substances that patients can potentially buy on the dark web and use modalities like blockchain, such as Bitcoin, to purchase and completely have them anonymously delivered to their home. And so that complicates the landscape, because sometimes we don't quite know what we're treating when it comes to withdrawal syndromes or lingering mental health side effects such as psychosis no longer are things what they are in our world. So, the synthetic fentanyl is, there's about 8 different variations that we know about, and we don't know what else is in there besides the opiate, which can be complicating some of these courses. So over the last couple of years, things have increased in frequency and intensity, but also complexity, kind of making our jobs just a little bit harder.
Why has there been such an increase in fentanyl abuse?
The increase in fentanyl abuse has slowly escalated in the first parts of the 2010s and then really started to take off in the late part going into 2020. A couple of things have kind of expanded its use. One is that's what's available. Fentanyl is now in our area readily available. And at first, it was kind of masked as other substances. So it was masked as a version of Percocet or a version of Vicodin, and people didn't quite know what they were getting. But lo and behold, they were getting a more addictive and deadly substance. And so it kind of created a market for people that became addicted to it. And so they increased the supply. But we're also seeing a bit of cross-contamination too into other substances. So if you are somebody that traditionally uses methamphetamines, there is a high rate of cross-contamination. And so whether accidentally or intentionally, the methamphetamines are also having fentanyl in them. And so some of the other substances that people use also are having that cross-contamination. And then we can look at the psychosocial factors of living in a pandemic and being isolated and withdrawn from family, friends, the economic climate, and people not knowing whether or not they will or will not have jobs or opportunities. That has a tendency to drive substance use, and it will drive people to what's available.
Yeah, it's really been a perfect storm. And in addition to that, the fentanyl that's on the street, it's not the prescribed fentanyl that or the ordered the medicine you get in the hospital. This is an analog that's created in labs, and it ends up being 50 to 100 times more potent than morphine. And kind of all these things together has created a really huge crisis that is now, it's overlooked a little bit. I sometimes call it the eclipsed epidemic, and it was eclipsed by the COVID-19 pandemic, which is certainly very concerning. But we're not talking about it as much as we were 2-3 years ago, and frankly, there's the treatment for opiate use disorder has expanded some, but it's not expanded enough. So there's not as much access to the medications and the psychosocial treatments that patients need in our communities.
How do you treat the psychosocial aspects of opioid versus alcohol addiction? Dr. Peterson?
Well, that's an interesting question because I don't think that there's a difference necessarily about the psychosocial treatments from alcohol to opioid use disorder, because you can have very similar psychological, co-occurring disorders. You can have very similar social determinants of health or social concerns that need intervening in both cases. What I would say is it's very crucial for the person who has alcohol use disorder or opioid use disorder to receive screening for all social determinants of health, for psychiatric disorders as a part of their treatment for addiction. It's not enough to just give somebody medications and detox them. We also need to make sure that their basic needs are met. Otherwise, biomedical interventions can only go so far. The results of addiction treatment are best seen when you have a psychosocial and a biologic kind of interventions all happening in tandem.
I totally agree. The gold standard of treatment is going to be this holistic picture, right? Look at the patient, assess the patient, and see what is not going in the patient's favor. That could be a lack of employment or education, safe housing, supportive relationships, um, opportunities for food sources. There's a lot of things that we have a tendency to take for granted when we are the clinician or the provider, in the sense that, I take for granted that I have a smartphone and I can easily make phone calls and do my health appointments via the telephone. And so sometimes our patients don't have access to those means. And so the treatment itself is definitely this well-rounded, put together plan using all the resources that we've got across the board, from social work to psychologists to physicians to pharmacists, et cetera. Everybody has a hand in this treatment modality. But what's interesting is the number of people that get screened in the first place. And there has been some recent data that has come out. We have a lot of big studies that look at, the number of times people use substances in the last month and 12 years and older, et cetera. And they came out with some recent data looking over the last couple of years. And only 9% of the time are people offered treatment that have a substance use disorder. And part of the problem is learning how to screen those patients and screen all your patients for these potential devastating diseases. And then we come up against the, modern medicine, family medicine appointment or primary care appointment. I was reading a recent study for a talk I'm giving coming up, and they have 18 minutes. They have 18 minutes to get everything done for roughly the average of 2.5 problems. And every problem that increases, generally the appointment only increases by 1 to 2 minutes. So if you're at 4 problems or 5 problems, you're looking at maybe a 23-minute appointment. And how do you get it all in? How do you screen and make sure you're getting everything in when you're also probably managing congestive heart failure or diabetes, chronic pain, a whole host of other things? And I think it's kind of one, education for those primary teams, but also reevaluating the importance of those frontline clinicians, because they're the ones that are doing the heavy lifting and then triaging to the specialist.
Totally agree. I feel like that the Toyotaization of healthcare both contributed to the opioid epidemic, and that we focus on high throughput visits and seeing more patients, and opioids were easy to prescribe, and they were easy to send folks home feeling good about themselves. And like, Dr. Lemke at Stanford says they go home feeling like they're wrapped in a warm blanket, and they can, receive that sort of anxiety relief. And that caused an issue with the opioid epidemic. And now we see, like Dr. Gumm saying, the high throughput health system that we have, especially in primary care, is not set up to respond to the opioid epidemic. And so part of responding to the opioid epidemic is demanding we change our healthcare structure so that we have time to take care of these really complex issues.
Thank you, Dr. Peterson. Let's talk a little bit about the stigma associated with addiction. What contributes to that, and how do we overcome the stigma? Dr. Peterson?
Well, I mean, stigma is a mark of disgrace that we place on people. And for centuries, people with addictions, whether it was to substance use or behavior or alcohol, were seen as weak. And what we're learning is that that's not the case. This is a chronic disease of the brain and its reward system. And a major risk factor for addiction is genetics. I mean, half of our risk of developing an addiction is related to genetics. And so stigma is seen on from a bunch of different angles. There's society's stigma about addiction. There's healthcare providers' stigma towards it or towards the medications we use to treat it. And then there's also internal stigma of patients with substance use disorder towards themselves. Self-loathing and low self-efficacy just kind of begets more grief and shame, which then can make the addiction worse. So on all angles, stigma impacts addiction negatively. it prevents people from, I think it prevents a lot of doctors from asking about addiction and screening for it. It prevents a lot of people from vocalizing it to their healthcare providers and asking for help. And then when people do get help, it sometimes will affect affect their long-term sobriety, or if they're on a medication that is stigmatized like methadone or buprenorphine, then they might get off of the medicine because their family member doesn't like that particular medication, and then they relapse. And so it's intertwined in treatment and is never a good thing.
Yeah, I think even, we are looking and evaluating addiction medicine as a field at how we even speak about it. For a very long time, we would say things like, oh, your urine drug screen is dirty or clean, and kind of attaching morality to it. And I think, as a field, we're definitely shifting the language to kind of decouple that moral failing from even the terminology that we use on a daily basis, because nowhere else do we use that language. If a diabetic's blood glucose is elevated, we don't say it's a dirty sugar. And so changing the way that we, even as a field, speak at it, which can potentially have a ripple effect, will hopefully change minds. And then as the field of addiction medicine expands and people become interested, that also has hopefully a wide outreach to show, hey, treating addiction, one, improves outcomes. It's not always a fight. It can be rewarding. And then other people will say, well, what's the harm in asking? Maybe I can tip my toe into the water of helping people with addiction. And that's how we've seen people change their perspective about other stigmatizing diseases and disease states. It took a few people or a coalition of people to really start treating a population to change the tide around the thinking. And that's what it takes. It just, unfortunately, can take some time, which in medicine means comorbidities and mortality.
The words we use can impact how we treat people. And if we are treating people based off of a bias or a stigma, that's discrimination. And one very interesting study looked at providers and how they responded to a clinical vignette. And the only thing that changed in the clinical vignette was the use of the word drug abuser versus a person with substance use disorder. So they use a person first lexicon. And they found that in the vignettes that have drug abuser in them, physicians tend to withdraw negatively or socially withdraw from that particular case, which might affect asking questions or spending time with that person, which would absolutely affect their health care. And we know that people with substance use disorders have worse outcomes than folks who don't. And so using language is really important. And like Dr. Gumm was saying, removing the stigmatizing terms is, I think, really important, and moving to a first person lexicon, like a person with a substance use disorder, which when asked, actually in one study, patients were asked, what do you want to be called by your healthcare provider? And most of them wanted to be called a person with an opioid use disorder, not an opioid addict and such. And so I think it's all important in helping to lower stigma and to help to create a welcoming environment for people when they come and ask for help.
Thank you, Dr. Peterson. Dr. Gumm, final question. Can you kind of describe the types of questions that providers can ask to help identify substance abuse in patients? And what's the importance of presenting the questions in a welcoming way?
The first thing I always tell people is to be kind and open, and have kind of a curious tone about things versus a very charged tone or aggressive tone or negative tone, whatever you want to call it. But a lot of times the way I even just open it up, and I talk to, I work with addiction patients every day, is, tell me about your recent use. If I know that they've been somebody using substances, and it's not, are you or are you not using? It's not kind of attaching either positivity or negativity to if they have currently been using or in long-term remission. It's kind of just addressing it with an open-ended question. And we have a few screeners for primary care physicians if they feel uncomfortable with kind of getting enough history. And there's some classics like the audit for alcohol use, which will evaluate for risky use or misuse of alcohol, as well as a couple of others. Another is a DAST. It's called DAST, and that evaluates for substance misuse or use among patients. And each one of those is about 10 questions long and are great tools. And we have looked at further reducing it down to just even 1 or 2 questions. And they've shown that just asking simple questions about, have you had any alcohol in the past year? And, if it's no, you move on, that's great. And 2, if it's a yes, you explore just a little bit further. Do you feel like you've had any consequences from your drinking, like losing relationships, or maybe it's impacting your work or your school, that type of thing. But simply just asking whether or not somebody has or has not been using is a great way to open up the conversation. And again, just curiosity tone, kind of looking to explore and, opening up the dialogue. And that usually helps kind of explore somebody's recent use of any substance and has been shown to be really effective.
Thank you, Dr. Gumm. Dr. Gumm, Dr. Peterson, any last thoughts?
I would say if you're a patient who is wanting some help, or if you're a provider who wants more information, there's a great free 24/7 confidential phone number you can call. The Arizona Department of Health has partnered with the Poison Drug Information Centers of Arizona to create what they call the Arizona Opioid Assistance and Referral Line, or the OR line. And that number is 1-888-688-4222. And it could either be a patient or caregiver who's looking for information, or a care provider who's looking for information can call in and talk with some skilled nurses, pharmacists, and physicians.
I will do a shameless plug for the both of us. I greatly enjoy my work, and my work is very fulfilling, and I'm very passionate about it. I felt kind of lost in general psychiatry, and there were times when um, I felt like I wasn't getting the progress with patients that I really was looking for. And when I started doing a lot of addictions work and became addiction certified, I really started to get the wins, to just kind of like see this amazing transformation and progress and see people do well and kind of change their life around. Addiction medicine has really given me that opportunity and kept me from having burnout. And with working with my fellows, I had one of my amazing fellows from last year reach out to me and say, I feel like this is the anti-burnout for some people in medicine. And you get to work with a niche population, you get to know a subset of diseases really well, you get to become a subject matter expert and really own what you're doing. Um, but the patient stories are what really, you get a couple of really great stories. And even on the hardest days, you're like, you know what, if I can just plant 1 or 2 seeds and help 1 or 2 people, it's all the difference. And so if people are interested, both Phoenix and Tucson, University of Arizona, have addiction medicine fellowships taking a variety of backgrounds. I know my program is open to psychiatrists, family medicine, internal medicine. We've had anesthesia, we've had ERPs, we've had a whole host of people, and we just know the more people that we train to be able to fight this epidemic, the more successful we're going to be long term.
Dr. Gumm, Dr. Peterson, thank you both for taking the time and sharing these talking points with our audience. Signs and symptoms of chemical dependency and substance abuse vary from person to person and can be influenced by a number of different factors or stressors. There are resources available, and I encourage anyone to reach out for help. Dr. Gumm, Dr. Peterson, thank you very much for your time. Our listeners can learn more about chemical dependency and substance abuse programs at Banner Health by visiting bannerhealth.com/services/behavioral-health. Thank you very much and tune in again next time on Making the Rounds podcast. Thank you.